Continuaremos con la conferencia magistral que termina el curso precongreso que está a cargo de la doctora Anna Lok. La doctora Anna Lok obtuvo su grado médico en la Universidad de Hong Kong y su formación en hepatología fue de la tutoría de la doctora Sherlock en el Hospital Royal Free en el Reino Unido. La doctora es profesora de investigación de hepatología en el Departamento de Medicina Interna de la Universidad de Ann Arbor en Michigan. Es investigador asociado clínico en el Departamento de Medicina Interna. Es la presidenta electa de la Asociación Americana para el Estudio del Hígado. Sus áreas de investigación y expertise son hepatitis virales B y C, enfermedad hepática y cirrosis. Su investigación se centra en cuanto a la historia natural y tratamiento de la hepatitis B y C. Cuenta con más de 350 trabajos publicados sobre las hepatopatías virales y es coautora en las guías de hepatitis B en la Asociación Americana para el Estudio del Hígado. Doctora Lo, es un placer tenerla con nosotros y su conferencia magistral torna en cuanto al tratamiento del virus B en poblaciones especiales, embarazo, HIV, inmunocomprometido y coinfección de B con C.
Well, thank you very much for the kind introduction and for having me come back. I first came to the Mexican Society meeting last year. So my task is to talk about treatment of the special populations of hepatitis B patients. Okay, these are my disclosures. So I'll talk about pregnancy, immunosuppression, HIV infection, and hepatitis C co-infection. This is really the latest thing. The first thing about pregnancy, we all know that one of the very important aspects of hepatitis B is prevention, particularly preventing mother-to-child transmission. And here, the most important thing is to make sure that we administer hepatitis B immune globulin and the first dose of hepatitis B vaccine in a timely manner. And if we do everything correctly, the efficacy is roughly 95% in protecting the infants from getting infected. Well, why do we not get 100% success? There's several reasons. One is because of delay in administration of the hepatitis B immune globulin. The second is when the mothers did not bring the child back to complete the 3 doses of hepatitis B vaccine. And the third thing that we learned in the last 5 to 10 years is when the mother has extremely high levels of virus, even if everything is done correctly, the baby can still get infected. So this is retrospective data from a study in Taiwan where all the babies got the hepatitis B immune globulin and the vaccine appropriately. And you can see that when the mother has very low levels of virus, the babies were protected. However, if the mother has high levels of virus, then the babies, despite the fact that they were getting the HB and hepatitis B vaccine, still get infected. And it looked like at a point when the mother's HBV DNA is more than 10 to the power 5 or 10 to the power 6, that's when the risks start to go up. And this really forms the rationale for the current recommendations that mothers with high levels of virus should be getting antiviral therapy. So the concept of giving the mothers antiviral therapy to further prevent mother-to-child transmission got way back more than roughly 10 years ago. This was the initial study looking at lamivudine versus placebo. And what you can see is that in the lamivudine group, based on intention to treat analysis, it was 18% infection in the babies versus 39%. But there were a lot of problems with the intention to treat analysis in this study, in that the mothers did not bring the babies back for testing. And when the babies were not tested, they were assumed to be failures. And if you do the per protocol analysis, it was 7% versus 18%. But we now do not use lamivudine because of the high risk of drug resistance. So this is a more recent study using tenofovir disoproxil fumarate, TDF. And this is also a randomized controlled trial conducted in China. All the mothers were e antigen positive with HBV DNA of more than 200,000 international units per ml. And they were randomized around about week 30 to 32 of pregnancy into either tenofovir, which was continued until 4 weeks after the baby is born, or to no treatment. And what you can see is that in the per protocol analysis, none of the babies born to treated mothers were infected compared to the placebo group, which was 7%. Now, a lot of people are very concerned if we suppress the virus for a short period of time and then stop, and the virus rebound, will the mothers experience hepatitis flare? Well, fortunately, this actually doesn't happen very often. And in fact, postpartum flare would occur even if the mother never received any antiviral therapy. So here you can see that the two lines, the tenofovir group and the control group, the ALT in general is pretty normal during pregnancy, but postpartum, both groups increase to the same extent. So there's really no worsening or increasing of hepatitis flare as a result of short-term antiviral therapy. Now, obviously, you would expect that the treated mothers, they had decline in HBV DNA while they were getting antiviral therapy, and when you stop, the DNA comes back up. So what do we really recommend when we have hepatitis B positive women who now get pregnant? Well, the first thing is we want to really assess both the HBV DNA level as well as the liver enzyme and the liver disease status of the mother as quickly as possible. If the mother requires treatment because the mother has active disease or suspected cirrhosis, we should be starting the mother on treatment because here we're trying to treat the mother and not necessarily in an attempt to prevent infection. If the mother has low DNA level, doesn't really require treatment right away, then you should recheck the HBV DNA and ALT level during the mid to late second trimester. And if the DNA remains low, you can monitor and make sure that the infant gets hepatitis B immune globulin and vaccine. On the other hand, if the mother has high virus level, the current recommendations, both from the US National Academy of Science and Medicine, as well as the AASLD guidelines, is that these mothers should be started on tenofovir, DF at 28 to 32 weeks, and of course the infant continue to receive HBV plus vaccination. So we can completely prevent mother-to-child transmission. And this is the goal of both the WHO as well as the United States National Academy, that to do so, we need to make sure the mothers get screened and that the mother's hepatitis B status is communicated to the delivery unit, because if you test the mother and no one knows in the OB unit, that doesn't help. And we need to evaluate whether the mother needs treatment for herself. If that's the case, go ahead and treat the mother. If not, then it's determined by the level of virus. If the mother has high viremia, then we start antiviral therapy around about the beginning of the third trimester to further prevent mother-to-child transmission. Now, what is important is that we must make sure that we continue to monitor these mothers. Oftentimes, after the baby is born, everyone forget about the mother, and we miss an opportunity to continue to follow these women with chronic hepatitis B. And we should also make use of this opportunity to screen and vaccinate other family members, for example, the father. Let's now move on to talk about immunosuppression. So when we talk about hepatitis B and immunosuppression, obviously the thing that we worry about is reactivation of hepatitis B. This basically is an abrupt increase in HBV DNA replication, and it can occur in both patients with chronic infection as well as those with past infection, so including people who are surface antigen negative, core antibody positive. And so you can see reactivation in several different formats. One is in patients who are surface antigen positive, and you now see an exacerbation of chronic hepatitis B. Or you might see that these are patients who currently have quiescent hepatitis B, and now it gets reactivated. As I've mentioned, you can also see reactivation in people who are surface antigen negative, core antibody positive, with or without surface antibody. And here you can get a seroreversion in the sense that the patient can now become surface antigen positive again, or occasionally just appearance of HBV DNA while they remain surface antigen negative. Well, what can trigger reactivation? We all know that cancer chemotherapy can do that, and we know that very well. But it's more than cancer chemotherapy. We now use a lot of biologics, and perhaps one of the worst would be the anti-CD20, such as rituximab, and that has the highest risk of causing reactivation. We know that steroids also can do that, particularly when you use it for more than a few days and in doses of more than 20 milligrams. Many other biologics, such as anti-TNF, anti-IL-17, CTLA-4, they all have been reported. Now, what is less clear is other sort of immunosuppressive agents which are not as potent, azathioprine, methotrexate, the risk is probably low. But even some of the molecular target agents have been reported to be associated with hepatitis B reactivation. So this list continues to change, and we have to really monitor very closely. So what are the clinical settings? Obviously, cancer patients. We tend to worry mostly about hematological patients, lymphomas and leukemias, but even solid tumors. And certainly patients who receive bone marrow transplant, stem cell transplant, that's a very big risk. As hepatologists, we see patients with hepatocellular carcinoma. When they get TASE, there are reports of hepatitis B reactivation. We think that chemotherapy, when it's given through TASE, is mostly localized to the liver, but it's not true. A little bit of it does get spilled into the systemic circulation. Now with all these biologics, we can see that not only on oncology patients, but also in GI patients, the inflammatory bowel disease patients, rheumatology patients, rheumatoid arthritis, lupus, dermatology patients, psoriasis. So we need to be aware of all these possible scenarios. So this is a patient who received some chemotherapy. The red lines indicate a post-chemotherapy. And you can see that initially liver enzymes were normal and HBV DNA was very low. But with immunosuppression, first you see an increase in virus replication and then the liver enzymes go up. And this patient either gets better or the patient dies. Or you put the patient on antiviral and get it under control. So this is a systematic review which shows you how frequently reactivation can occur. In patients receiving chemotherapy, you can see reactivation and hepatitis flare in up to 30 to 40% of patients. And what is worrisome is really potential for liver failure as well as death. So what are the risk factors? It doesn't happen in everyone. It looks like there are host factors. Men are more likely than women. Disease factors, hematological malignancies, especially lymphomas. Treatment factors, obviously intensity of immunosuppression, conditioning therapy for bone marrow transplant, and as I've mentioned, use of anti-CD20. But there are also viral factors. So this is what happens. Surface antigen positive patients with detectable HBV DNA have higher risk than those with undetectable HBV DNA or those who are surface antigen negative core antibody positive. But we can prevent it. And if we use prophylactic antiviral, which means that we start the antiviral at the time when we start the chemotherapy or even before, we can prevent reactivation in up to about 80%. And we can certainly prevent death in 80 to 100%. And we can also reduce cancer-related death. You say, why would antiviral therapy also help cancer-related outcome? Because when the patients have a flare as a result of HBV reactivation, what do the oncologists do? When they see the ALT of 400, they freak out, they stop the cancer chemotherapy. So the patient is not getting the cancer treatment. And so if you prevent it, the patients can get the intended treatment. And so it also helps with the cancer-related outcome. And prophylaxis is better than therapeutic. What does it mean? So prophylaxis means that you start the antiviral therapy at the beginning of immunosuppressive therapy, or just before, or right around that time. Now, therapeutic means that you wait until the ALT start going up. Now, of course, at that time, the damage is already ongoing, and you may not be able to control it. So when you compare the prophylactic group and the therapeutic group, you still have bad outcomes occurring. So the message is really you need to screen the patient and offer them the prophylactic antiviral therapy and not wait for bad things to happen. Many of the initial studies use lamivudine, but we all know that lamivudine is not a very good antiviral because of the high rates of drug resistance. And this is a study comparing entecavir with lamivudine. Not surprisingly, the entecavir group did better. And this is because some of these patients, the prophylactic period lasts for more than 3 to 6 months. And when it lasts for more than 6 months, there's a chance of drug resistance and breakthrough and flares as a result of the breakthrough. So what do I recommend? If you know that the patient is going to start on immunosuppressive therapy, I would check the patient for surface antigen and for core antibody. And if the core antibody is, and for the patients with surface antigen positive or core antibody positive, I will also check a baseline HBV DNA. Then depending on the type of treatment the patient is going to be put on, if the risk of reactivation is high, I will put the patient on antiviral prophylaxis. If the risk is moderate, one could argue that you can monitor the patient and start antiviral therapy when you see the HBV DNA goes up. But I find that it's always difficult because the patients are always seen oncologists are not necessarily coming back to see us, so we may not be able to monitor the patient as closely as we would like. For the patients who are low risk, you can monitor the patients, and certainly for the patients who are seronegative, you can just monitor the patients. So the next group I'm going to talk about are the patients with HIV co-infection. We all know that this is common, particularly in countries where hepatitis B and HIV are both common, and worldwide it's estimated that roughly 10% of HIV positive patients also have chronic hepatitis B. The co-infected patients tend to have higher DNA levels. The likelihood of spontaneous E seroconversion is much lower, and certainly the chance of spontaneous S antigen loss is close to zero. We oftentimes find isolated core antibody among HIV positive patients, meaning they're surface antigen negative but core antibody positive, and it's recommended in the HIV literature that you should offer these people hepatitis B vaccine, even though some of them may have prior exposure already. And the vaccine response may be impaired, particularly if the patients present with advanced HIV infection with a low CD4 count. So in some of these patients, you might actually want to treat the HIV, get the immune response better before you vaccinate them. Otherwise, the vaccine may not work. When we started 15, 20 years ago, we said that, well, you don't treat all the HIV patients, you wait for the CD4 count to drop. We now know that this is not a very smart strategy, and so the current recommendation is that we should really start pretty much every patient with co-infection, regardless of the CD4 count. And we need to be very careful in picking the regimen that should contain at least 2 drugs with HBV antiviral activity. So this usually means tenofovir plus emtricitabine. The treatment should be continued indefinitely because you're not going to stop the treatment and hope that everything will be okay. At times, we would change the antiviral regimen, and it is extremely important when you switch from one therapy to another that the patient continue to receive drugs with HBV antiviral activity, because otherwise you're going to cause a flare of hepatitis as a result of viral rebound. And obviously, counseling the patients on adherence to the medication is very important. So what are the usual regimens? The usual regimens are really nowadays fixed dose combination. We no longer have patients take 30 different pills and set an alarm clock to wake up in the middle of the night to take the pills, because we're able to really bundle them together. And most of these combinations will contain tenofovir disoproxil fumarate and emtricitabine, although many of them have been replaced. As many of you probably know, tenofovir has a new formulation, which is tenofovir alafenamide, or TAF. It has the same antiviral activity, but with less kidney and less bone side effect. And for hepatitis B monotherapy, there is a monotherapy regimen, Vamlidi, which has been approved, but there are several fixed dose combinations, including TAF and FTC. And because these patients are going to require lifelong treatment, having a drug with less side effect is obviously an advantage. Well, one thing that we always worry is that in co-infected patients, when the ALT goes up, what exactly is causing it? Well, there's several possibilities. It could be hepatitis B related, it could be HIV related, or it could be other thing else. So hepatitis B related, well, a patient may have hepatitis B related liver disease like any mono-infected patient. We also recognize that there's a situation which we call immune reconstitution. This happens when the patients with advanced HIV present with very low CD4 count. You put them on HIV treatment, the immune response gets better, and now the immune response is able to recognize the hepatitis B and cause the hepatitis B disease. It could also be due to immune clearance, because you put a patient on hepatitis B antiviral therapy, the DNA comes down, the patient may be going through E seroconversion, and you can also get a flare. And certainly when you change the HIV regimen and you forget to put the patient back on HBV drug, then you get a viral relapse. And if you get drug resistance because you didn't really put the patients on the right hepatitis B drugs, like in the old days when we used lamivudine. It could be HIV related. If the patients present late, it could be opportunistic infections affecting the liver at biliary tree. And it could also be ALK-related drug-induced liver injury, although the safety of these drugs have improved significantly in the last 10 years. And some of these patients do have steatosis. Fatty liver does occur in HIV patients as well. And finally, let me just wrap up by talking about hepatitis C, because this is really getting a lot of people nervous. What exactly am I supposed to be doing? Well, why is it that we see patients with hepatitis B and hepatitis C co-infection? Because of shared risk factors. People sexually who are promiscuous or had shared needles and used drugs, they may be exposed to not one virus but two viruses. And certainly more common in countries where both viruses are common. They have more rapid disease progression, higher risk of cirrhosis as well as liver cancer. In general, one virus tends to dominate. Hepatitis C that replicates more actively and the B being suppressed. But it's not always the case. Occasionally both viruses can be active. Occasionally B can be the dominant virus. And because in most cases one virus suppresses the other, so you can imagine that if you now put one of these patients a therapy, which very quickly drops the hepatitis C, then the virus, the hepatitis B virus, would no longer be suppressed and can bounce back up. So the FDA issued a warning, and because there have been reports not only of hepatitis B reactivation, but also mortality reactivation. In some cases, but there was also ALT increase. And for those reasons, surface antigen positive patients with detectable HBV DNA, it is safer to cover them with antiviral therapy for hepatitis B while they're receiving DAA therapy. And of course, if you decide to take them off treatment afterwards, you need to watch out for flares. So just to wrap up, hepatitis B reactivation is common during XIV DAA treatment, but hepatitis flare is not as common. So you oftentimes see an asymptomatic DNA increase, but significant ALT increase is not very common. The key is really to be on the alert. Test all the patients with surface antigen and core antibody before initiation of treatment. And for surface antigen positive patients, we should also test them for HBV DNA. And if they meet criteria for hepatitis B treatment, go ahead and treat both the B and the C. If the DNA is very low or undetectable, you should be you should be monitoring both the DNA as well as ALT and initiate hepatitis B antiviral if you start seeing hepatitis B reactivation. For surface antigen negative core antibody positive patients, which is quite common among the hep C patients, what you can do is you can monitor ALT. In general, when you put a hep C patient on DAA therapy, as the XIV RNA goes down, your ALT should actually go down. If the ALT doesn't go down but goes up, there's something wrong. And those are the patients in home, you should be rechecking hepatitis B marker and initiate antiviral therapy if necessary. So I hope that I've given you a glimpse of all these sort of unusual patient population and some suggestions for management. Thank you.